Good morning, everyone. Thanks for the opportunity to present our study about palliative care team consultations, circumstances around patients' death in ICU. The purpose of this presentation is to show why patients in palliative care have died in Brazilian ICU. This is a retrospective Brazilian study conducted in a private Brazilian hospital, Sírio-Libanês Hospital, where I work in a palliative care team and in ICU as intensivist. We don't have any conflict of interest to declare. Let's start with some questions. What would you like to do if you had a very serious illness and less than 1 year life expectation? I know this is an open, difficult question, but it might be easier to answer. Where would you like to die, considering that? Home, hospice, hospital, ICU. So, what about our patients? What do they think about it? In 2007, Bernardo did a study in USA asking patients of Medicare. And when he asked elders where they would rather die in that hypothetical scenario of less than 1 year life expectation, less than 10% of patients said they won't die inside a hospital. But in reality, near 54% patients die inside hospital. And more than this, analyzing USA data, we see, in fact, 25% of patients die inside ICU. I'm also an intensivist, so we are used to seeing patients dying in ICU. The problem is not dying, but if this high-technology treatment may not be targeting outcomes that are consistent with patient values and preference. So, aiming to decrease the gap between patient's preference and current reality, we analyze some characteristics of patients followed by a palliative care team who die in ICU, looking for factors that could be targeted in future studies. We perform a retrospective analysis using data from this questionnaire of palliative care team collected by our team nurse, Valeria. This questionnaire is a part of our service routine, and our nurse collect data in all admissions of new patients who start to be followed by palliative care team. So far in our institution, we haven't used any institutional trigger to palliative care team. So in this study, all referrals depend on approval of the primary medical team. This data was collected only on admissions and outcomes, and we don't have collect any information between these 2 points. So, a total of 628 patients were attended by palliative care team from June 2008 to December 2013. 450 patients died inside hospital, 71% of all entire population of palliative care team, palliative care patients. 28% had hospital discharge. Among them, 76 or 17% of all deaths died inside ICU, and 82% died outside ICU. I will show the baseline of this population and then compare these two groups. Due to missing data, we exclude 7 patients, so we analyzed 443 patients. The mean age was 67 years old. Half of the population were men. The main diagnosis was cancer in 80% of patients, and followed by less than 10% of neurological disease. The most important reason for referral to palliative care team was less than 6 months prognosis, followed by burden symptoms, and conflicts needed to be mediated. As you can see, in some cases, we collect more than 1 reason per patient. Here, we can see that at the time of referral, 50% of them had an advanced directive written on medical record. After followed by palliative care team, at the moment of death, 82% had this information on medical records. And in fact, 82% was less than we expected, so we analyzed to deeper this information. And here I highlighted our learning curve. And the last few years, we had improved, and over 95% of written advanced directives in the medical records. Here I show where the patients were when we were called, like 85% were from outside ICU and 15% were from ICU. And here I show where the patients were when they died. 82% outside ICU and 70% died inside ICU. It seemed very similar to where they were on referral and where they die, and in fact it is similar. Only 3% of all patients were withdrawn from ICU before their deaths. And so here's that one of our hypotheses, that the unit of referral was associated with place of death. I'd like you drawing your attention for these graphs. Here I outlined the comparison between patients attended by palliative care team who died in ICU and who died outside ICU. It seems obvious, but we could confirm our theory that more frequently patients who died in ICU were in ICU when referral, were receiving life-sustaining treatment when referral, such as mechanical ventilation and vegetative drugs, and had less advanced directives on writing medical records. Here I show an interesting finding that cancer diagnosis in our population was more frequently to die outside ICU. Cancer could be seen as a protective factor in this case. On the other hand, conflict, as expected, the conflict as a reason to call palliative care team was associated to die inside ICU. To conclude the results part, I present this Venn diagram, which analyzes better who was involved in conflict case. As you can see, conflict between physician and family happening in about 50% of cases. According to our research, I got in 3 main conclusions. As shown before, oncological patients had less aggressive treatment in end-of-life care. Discussing palliative care in non-cancer patients is the new challenge, mainly in neurologic patients and elders. As conflict and non-established advanced directives were associated to dying in ICU, communication and conflict mediation should be the main objective in intensivist palliative care training. As I showed before, in our population, using life-sustaining treatment when referral to palliative care team was associated to death in ICU. This could be explained by the fact that withdrawing life-sustaining treatments are unusual in Brazil. Despite the consensus that there is no legal or ethical distinction between withholding and withdrawn treatments, in practice, patients, families, health professionals report a disturbing difference between these 2 points of view. Moving to the conclusion, for patients attended by palliative care team, the circumstances associated with death in ICU included a non-cancer diagnosis, the use of organ support at the beginning of palliative care team consultation, and a lack of written advanced directive of end-of-life care. And thinking about future, we believe that early evaluation of values and preference by palliative care team could reduce ICU admission and lead to a more proportional end-of-life target. Thank you very much for your attention.
Cesar, thank you very much for your talk. A lot of data poured out over us.
Sorry.
Floor is open.
I don't know if this is working.
Yeah.
I'm a critical care physician from Canada, and we are increasingly incorporating palliative care physicians even in elective cardiac surgery patients who stay more than a week. The question I had was, what strategies do you use as palliative care physician and intensivist to mediate conflict and improve communication? What specific strategies?
Thanks for your question. It's a difficult question. I think is the first we try to get a consensus with doctors, then ask then we have a meeting with families and trying to do like understand point of views we don't have a different strategy. I think time, listening families and listening doctors is the way to mediate this kind of conflicts.
That's a very good comment that you start with the physicians, because we often see a difference of views between surgeon, I'm also a surgeon, so surgeons and what ICU doctors want. So is it a good idea to start to get consensus among physician group and then family?
I think so, because it's very stressful for the family to put different way of thinking, and the first time it's better to understand what they are thinking, understand the point of views, and then try to mediate this kind of thing. In my opinion, sorry about my English.
I want to stress that point. I think it's essential that the professionals reach consensus amongst each other, and professionals is nursing staff and doctors all together before you can contact the family or fight out a conflict with the family.
Yes.
If they sense that the team is split, then I think that's a reason for conflict. Any more questions?
And Professor, you say something important for us. Yeah. We usually to ask nurses and therapists, other people about their opinion, yeah. And because what you said, yeah, it's the same opinion.
It's very important. In your slides, you mentioned that almost everybody at the end had an advanced directive, but I think you mean limitation in care.
Not exactly.
Yeah.
Yeah. In some cases, we explain.
Do not resuscitate or things like that.
Yes.
Yeah.
The important thing is have a directive inside the medical records, not limitation medical records. I think the most part of them that we write about limitation, but some of them it's do everything. Yeah. To resuscitate and everything. It's like 3 cases we resuscitate patients in palliative care in 600 patients.
Okay. Mm-hmm. And you said you played a role as an intensivist and a palliative consultant. Do you really walk rounds, or do you give advice to your colleagues in intensive care to use analgesias or sedation? What's your exact?
No, in ICU, I work as an intensivist, yeah. And in part of my time, I work in a palliative care team, like 3-4 hours a day, and the other part I work as an intensivist. Mm-hmm. But it's very important that people know that you work in palliative care, so they usually ask me questions or discuss patients or families about our team families. They usually see us like a palliative care team inside ICU too.
Mm-hmm. Thank you very much. Another question, please.
Dominique Benoit from the Ghent University Hospital in Belgium. Do you think that it is a good evolution that we need palliative care specialists in the ICU? Should the endpoint not be that every physician should do palliative care?
Excellent question. I think both. I think we have, it's not one on another. I think we can do both things. Like intensivists must to be training in palliative care settings, and on the other hand, palliative care team, it's a multidisciplinary team, and it helps a lot when the patients go out from ICU and to take care of him in the wards. So, and we are usually should have difficult discussions. So I think both. I think we can do this together.
Learn from each other, yes. Thank you.
Does this answer your question, Dominique? Yeah.
Yep.
I think every intensivist is a sort of a palliative care physician,
yeah.
in his role. Any more questions from the floor? Yeah. Of course.
You were presenting results from the US about how many people die at hospitals. Do you by any chance have any data from Brazil?
Yeah, this is a very important question. We don't have information of number of patients who die inside ICU. In fact, I put a slide here that I show that patients could vary in different countries where they die, but we don't have this clear information in Brazil, and the information we don't have is how many these patients die inside ICU in Brazil. Thanks.